Welcome back to the PFC podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC podcast. This is Dennis, and today I'm with Jeremy. How are you doing today?
I'm great. Thanks, Dennis. Appreciate you having me on the show.
I definitely appreciate you jumping on the show. If you wouldn't mind just doing a real quick introduction of yourself.
Sure. So I'm Jeremy Pamplin. I'm a critical care medicine trained physician who spent a little over 28 years in the military. Just retired a few months ago as a colonel. Retired at the Telemedicine Advanced Technologies Research Center, where I was the commander there and deputy director for about 7 years. Spent quite a bit of time in the burns and trauma community when I was down in San Antonio at the Brooke Army Medical Center and the Institute of Surgical Research Burn Center. Have been a part of a variety of technology developments throughout the military healthcare system for the last decade or so, doing things like the checklist revolution that we've used in many of our ICUs. Our telemedicine systems, primarily our virtual health for operational forces system, which we call Advisor, or the Advanced Virtual Support for Operational Forces, which was, I think, where we actually first met many years ago, and have been involved with our ECMO development, our telecritical care development, and then trying to develop autonomous systems for combat casualty care while I was at the Telemedicine Advanced Technologies Research Center. And now I've moved over after retirement to DARPA, and I'm a program manager here in the Biological Technologies Office, and developing, again, continue to live the dream of developing advanced medical technologies for the warfighter and for combat casualty care. My current programs are F-sharp, or fieldable solutions for hemorrhage using bioartificial resuscitation products, quite a mouthful, but essentially synthetic whole blood that is shelf stable and can be given at the point of injury. And then the DARPA Triage Challenge, which is really about using autonomous systems to help us triage casualties and mass casualty events, which I think is the primary focus of today's podcast.
Yeah, I didn't know about the sharp fake whole blood thing. I'm going to have to hit you up on that one. But
happy to talk about that.
So I don't know, was it 4 months ago or so? I started getting pinged about the triage challenge with DARPA, and definitely a very difficult kind of situation. Having been through some myself and watched others, it's always chaos. And so DARPA, of course, applying technology and robots towards this. Like, what was the challenges? Like, how did it go?
Sure. So the DARPA Triage Challenge, I mean, the robots and the autonomous systems, certainly gain a lot of the attention of the DARPA Triage Challenge, but fundamentally it's not just about the robots, the automation. It's really about how do we enable or help medics, care for more casualties during these kind of chaotic events, right? Where really seconds matter, right? And the decisions that you make for every individual casualty, as you well know, really makes a difference, not only for the casualty in front of you, but also for all the other casualties that you have to manage and take care of. So we are now in the second year of the DARPA Triage Challenge. Actually, we just finished the second year of the DARPA Triage Challenge. We're now into the third year. The challenge was actually initiated by one of my predecessors, Dr. John Paul Credian, who was a Navy physician. Not holding that against him at all, but he developed the DARPA Triage Challenge with the intent to use data and autonomous systems to identify information with sensors that would identify signatures within those sensor streams that could help us identify casualties and really triage them and put them into categories, figure out which casualties should be seen first, second, third, fourth, and then determine how we might be able to modify a first responders. It doesn't have to be a military medic. There are certainly civilian applications to the DARPA Triage Challenge, but understanding how to inform those first responders, whether in the military or in the civilian emergency medical system, to optimize their response and maximize kind of lives saved. So in our in the throughout the program, there's been different portions of the competition. In fact, in the first phase of the first year of the competition, there were three components. There was the systems challenge, which is kind of what gets sort of a lot of the attention because of the robots. That's the find the casualties that are out there, assess them, put them into bins. We had a virtual challenge in the first year, and the virtual challenge was essentially a systems challenge, a physical a representation of that physical challenge in a virtual domain. So could you replicate? It's very difficult, as you probably well know, to do med sim of a really large scale mass casualty. Once you start getting past the 20, 30 casualty mark, it's really hard to kind of scale that up and do hundreds or thousands of casualties at a time. So we had imagined at one point, or JP had imagined, that we would have a virtual world where we would be able to simulate that type of mass casualty event. And then we have the data challenge, which has been termed kind of primary and secondary challenge events. And as you know, there's an element of care that you do during the initial response to the mass casualty event, where you have to go out and find and sort all the casualties. But the medical people do that finding and sorting and then categorizing of casualties, not just based off of the current, situation for the casualty or their current status, but also with knowledge and understanding of what the future holds, right? So there are casualties that are in such extremis that if you had unlimited resources, you'd probably take care of them. But because you don't maybe have unlimited resources, or you can't get to those resources in a timely fashion, we manage those casualties differently. So the data competition, or the secondary triage competition for the DARPA Triage Challenge, looks at the first essentially 4 hours of casualty care using data from the civilian healthcare system. So maybe an ideal situation at major trauma centers. Our partners are the University of Pittsburgh and the University of Maryland, and they collect data for us during initial evacuation or the emergency medicine vehicle back to the trauma bay and then up to about 4 hours of their initial hospital course, so that we can use all of that data to understand kind of the predictive map of what casualties might need, so that in the future, we could potentially apply that information to the actual triage event. So in year two, again, a challenge competition at DARPA is really about increasing complexity of the challenge on a year-to-year basis. So if you go back and you look at the DARPA Triage Challenge website, which is open online, you can see our event number one. And there's some casualties in the scenarios, but it's not terribly real, right? We have an ambush scenario, and all the casualties are kind of laying mostly out in the open. There's not a lot of smoke. There's not a lot of gunfire. There's certainly no fire. The casualties are not, really moving around or yelling a whole lot. The injury patterns are pretty realistic. And then we had a plane crash event. Was same kind of thing, right? We had, casualties that were protected from the potential, autonomous systems falling out of the sky. We had them in kind of, netting, protective netting. So, and all the casualties had, little QR codes next to them. So it was easy for the systems to find them. So that was year one. It was like really easy I wouldn't say easy. The teams were definitely challenged by doing this, but it wasn't necessarily as hard to find the casualties. They weren't moving at pace or at speed, and the casualties were really not quite as ill or injured. And then in year two, we at this last competition event, which is what caught your attention, and it's certainly exciting because it's catching the attention of many others. We upped the ante, right? And we took the protective, gates away, the protective netting away from all the casualties. We took those, wonky QR codes away from the casualties or the fiduciaries. So now the teams had to go out and actually find the casualties in realistic environments. We had a daytime environment in kind of a wooded-like area, and then we had a nighttime environment, which was another ambush site, but now it's at night. And the teams had to go and navigate these environments, find the casualties, and assess them. And then this year, for the first time, we brought in at the kind of end of the competition, mostly in an exploratory fashion, we brought in medics. And we asked the teams to actually work with, these were conventional force medics, so maybe not the same training background and experiential background as some of the folks that, are potentially listening to this podcast, certainly your background. But these were conventional force medics. And, they had to respond to these mass cal events with the aid of the robotics and autonomous systems. And it was an exciting thing to watch. I remember staying there with some colleagues and just kind of, at the end of the event, taking a step back and just appreciating the fact that this is the first time we had ever seen autonomous systems working with human medics in a way that actually made sense to us. So it was a really phenomenal event.
No, that sounds awesome, especially, integrating with the medics, right? Because that's going to be the whole point. The robotics, whether they be ground-based or drone, aerial, like they're not providing any treatment. Are they?
Not yet.
They're finding them. They're finding the patient, right? Are they like marking them or just like geotagging kind of thing? And then are they working with is the medic doing the assessment and then passing up that information, or is the drone just like tricorder scanning and like, this is all the things that are wrong with them?
Yeah, great question. So we, as a competition event, we set it up so that the teams had to report or get scored on various aspects of a mass cal triage type scenario. So the teams, again, you can probably refer to the website to see all the different teams we had involved with the CE2 competition event 2 or challenge event 2. But the teams use different combinations of UAVs, uncrewed aerial vehicles, or UGVs, uncrewed ground vehicles. Some teams were pure UGV, some teams were pure UAV, and most of them were actually a mixture of both. And what we try to do is set up a scenario where it was, similar to what you might get for like a quick reaction force, right? Where there's an event that occurred out there, and clearly the UAVs are just going to get there faster, or maybe they're already present as part of your ISR system or something. They're just present, right? And those UAVs were then allowed to start collecting data and identifying kind of the field, like where is everybody? And that information got pushed back to a tablet, right, through some sort of a mobile device, through a network. And the medics were then able to start seeing casualties populate on their map, right? And they would know where they needed to go. They would have a better sense. This year, again, was still very preliminary. Most of the intervention that the information that came back was mostly location data, right? There was some color coding for some of the teams about priorities or maybe suggested priorities, but most of it was information data. And what was fascinating watching is even just with the location data, which was only available about 5 minutes ahead of time, we did have medics run the course by themselves, so they would just go out. We had 2-man teams basically, and the course was between 20 and 30 casualties. And the medics would run out on the medic only courses, and you've been in these situations. The only way to do your assessment is basically casualty by casualty. You can yell out, if you can hear my voice, walk to me. We didn't have many of those casualties on the battlefield. Like we were trying to maximize, the difference that we could find with survival. But that's still a relatively small number of casualties depending on the event. And otherwise the medic or somebody is running casualty to casualty in a kind of linear fashion and bounding between casualties and getting to as many as you possibly could. And the difference that we saw, and we were tracking their, how they move between casualties, the difference between the medic only course and the medic machine course, or the human machine teaming course, was pretty profound, right? And what we did in AR talking to these medics afterwards is, it's when you get into those situations and you're dealing with real humans, particularly real humans that you might know, it's very easy to get tunnel vision, right? And you're focused, your head down, and you don't even realize how fast time is passing sometimes. And unless you know, kind of, you have a sense of just how many casualties are on the field, you don't even know how fast you have to move. And we saw that in real time, the non-human machine team, just the medic only team, kind of ran out, and at least one of the medics in the team got head down, got task saturated, and spent a really long time with the first maybe 5 to 10 casualties. And then all of a sudden they kind of looked up almost halfway through the run of the course, and they looked around like, wow, there's still a lot of people out here. And you could see it in the timeline. They started moving faster. And what you didn't see that at all in the human machine teaming course, because they knew ahead of time kind of the volume, and the distribution of where the casualties were. So, in the human machine teaming course, almost universally, the medic team split immediately because they knew how many people were out there. They didn't do any teamwork. They just said, we got to go split. And they started, you know, moving out through the course. In a few cases, they did a little bit of, I think this will hopefully get better this next year. They didn't do a lot of skipping of casualties. They were still pretty linear this year. But I imagine as we get better at populating the information into the system, that they'll have a better sense of where they should go first, second, third, et cetera, and be able to really prioritize who they're seeing. That's my hope for competition number 3. I think the only other thing I might say is that, a couple of the teams had the ability for the medics to kind of interact with the UGVs. And it was really fascinating. Again, you've been in these situations. Medicine is a team sport. So, you are talking to the casualties, you're managing the casualties, but you're also constantly queuing off of the other people that are in your AO. And you're saying, hey, Dennis, I got a guy over here. You need to come over here next. I can't do this. I got to go over here. Right. Or, hey, I'm, non-medic. Hey, medic, I need you over here. This guy's really sick. And you kind of hear and you cue, you look up, you look at them and you say, okay, I'm coming over there next. Right. And you use your maybe non-medic providers and the other medics around to kind of prioritize what you do next. What was fascinating in this scenario is the medics did the exact same thing with the UGVs that were able to interact with them. Right. So if there was a UPG that was over there assessing a casualty and the UGV said, I've got a critical casualty, and it cued verbally, and said, hey, this guy's over here. The medic looked up and said, okay, robot, they actually gave it a name. I'm coming there next. Right. And without even thinking, when they were doing this casualty, they didn't go anywhere else. They went straight to where that casualty had been queued for them to go next. And it was fascinating to watch. And again, I don't want to talk about the statistics and the kind of survival rates and things this year, because they weren't powered for this. This was very exploratory, very small numbers. We only total of four runs for all of this. But at least in the human machine teaming courses, we didn't do any worse than the human only courses. And pretty consistently, we did a little bit better. So in terms of saving lives, and that was our metric, how many lives can we save on the battlefield? So that was very reassuring to me that we didn't get worse. It's easy, it's easy to introduce technology on a battlefield, especially for medical care, and it's distracting. And, the medics, the good medics out there just kind of look at it, and this is not helpful. And they throw it in their ruck or the ground.
Right. Yeah, if you're lucky, they'll just leave it in the ruck. I mean, to be honest, what you're describing is actually pretty incredible, considering, like, visual technology, just finding the guy.
Yeah.
If whether it be thermal or some kind of LiDAR or just high fidelity cameras, you're able to find a guy who's hopefully he's moving, maybe not, but he's wearing camouflage, which doesn't make it easier. And he's probably covered with something from the environment, whether that be debris or he's under a vehicle, God forbid.
Yep.
It makes it drastically harder. So just, were they able to find all of them? Did anybody, get missed?
Yeah. So this is a competition. And each year it gets more complex and harder. So we absolutely had some casualties, like at the night course, that were inside some of the vehicles. And we absolutely had some of the casualties that were under bushes. In the plane crash course, there was a casualty that was essentially under the back wing of the plane. We had casualties that were under debris. No full occlusions in this year. Next year we'll have full occlusions of casualties, but so all the casualties could have been seen if they were seen. And by and large, the machines in the human machine teaming runs combined with the medics. So we weren't looking at the machines by themselves or the medics by themselves during the human machine teaming runs. By and large, the combination found more casualties than the humans alone, or the machines alone, which makes sense. That tracks with most of the literature that is out there about AI and automation of medicine. When you combine the machines with the humans, that's a better product than the human or the machine alone. So that was pretty reassuring. Did we find everybody? It's a common question, but I always want to caution people: the humans don't find everybody all the time. So I think if we can outperform the baseline of the human, then we're moving in the right direction. I don't know that the target is perfect or 100% in any of these disaster scenarios or any of these military scenarios. You did bring up one important point about just the challenge of this competition in general, which is that, especially in the military, but also in disaster, training these AI systems to do the work is a tremendous task. It's really hard because where do you get the data set for it, right? I mean, most of the off-the-shelf, commercially available or just open source models that help us identify humans come from things like Connect, right? The Connect video game where you just have a camera standing up and you're playing a video game, you're standing upright and you're doing stuff, right? Or just from humans walking around doing their day jobs. There's not very many data sets of humans laying on the ground, right? Or even sitting in weird positions, or certainly not in awkward positions of combat casualty care or disaster medicine, right? As soon as or people with missing limbs or, whatever it might be, or wearing camouflage, right? Camouflage is designed to hide you and machines have to be able to distinguish that. So there's been quite a bit of work done for the project, both as part of the DARPA project, but also in my previous work at Tatrick to just create some of these data sets that allow us to be able to identify and register that there is a human in the scene, that there's, they're normal or abnormal. So that's part of the challenge.
So you mentioned the machines doing the assessments or doing some version of an assessment, right?
Yeah.
I can't imagine it's doing some kind of vital sign. Is it just like, hey, this guy is missing something? He's supposed to have 2 arms, he's got 1. But how did that go?
You'd be surprised. So the original intent of DARPA Triage Challenge, and I'll try to channel my inner JP a little bit. I don't want to speak for him. There's a Word Docs podcast for JP if you want to go listen to that. But finding these signatures of information within data sets is really a core function of the DARPA Triage Challenge. So, I would imagine many of your listeners are aware that there are apps for your cell phone, right? Your mobile device that can use a camera to look at your skin and give you a heart rate and respiratory rate, right? That are in the App Store. So there are technologies that allow the computers with, various different sensors, and the teams have various different sensors. Cameras, obviously, is one. I'm not going to go into all the different, types of sensors they have on their devices, but, you can make multimodal sensing available so that it is easier to identify actual physiology of humans. So the assessment of physiology is absolutely a part of the program. The assessment of mental status is part of the program, right? Are you normal? Are you walking around? Are you really not much of a casualty, a minimal person, or not a casualty at all, right? Or do you have a traumatic brain injury, right? That's part of this challenge. And the teams are increasingly getting better and faster at it. I'm a new program manager. I started last summer. And, what I witnessed at this competition this year, I was able to go to the competition last year, but what I really witnessed at the competition this year is that because we were prioritizing accuracy of assessments, some of the teams were spending a lot of time doing those assessments, right? So getting more accuracy is oftentimes a function of more time. And sometimes we don't really want to do that, especially when you have a lot of casualties out there. So this year we've actually we are going to break up the competition and actually reduce we're going to have 2 different, what we call lanes. We're going to reduce the competition to lane 1 and lane 2. And lane 1 is a bunch of gates, which are basically deconstructing all the different algorithms that are needed to do the triaging. So there's a find and locate lane. There's going to be a physiology assessment lane. There's going to be a rapid or first pass triage lane. And then there's going to be a second pass or more kind of accurate or trauma assessment lane. Right. And all those combined will give us a really good understanding about how well the algorithms are performing and at what speed and what pace. And then we can move into the Lane two, which is really what we've been doing over the last couple of years, which is simply going out and finding the casualties in a disaster scenario, prioritizing their assessment for the medics, and then watching how the medics respond, and ideally having the medics get to the casualties who need care first, saving those lives, and then moving on to the subsequent casualties so that we can save the most lives.
The UAVs or UGVs, whatever mode these robots, they get there first because they're faster. Yeah. They do their assessment. They're saying, hey, I prioritize your patients for you 1 through 20, right? Did the medics listen? Or did they visually, like, that guy looks worse, I'm going to do that?
Again, I don't know that we have strong data on this yet, because the work that we've done thus far has been pretty exploratory. So, and I don't necessarily know that there's only 4 runs of this, so I don't know that I can give a lot of anecdote. I can talk about what the medics said afterwards, okay? And I mean, you've done some of these technology assessments in your past. I've done many of them, and it's good clinicians, medics, docs, nurses, whoever. When you give them bad technology, they know it instantaneously, right? It's like, this is not helping me at all. This is useless, right? I'm not using it, right? And it's almost a gut reaction to some of this stuff. You also have the converse of that, right? Which is, wow, I can really see how this could be used. And they engage and they give you feedback and they say, man, it did great at this. And if I could just get it to do this too, I'd be really happy. And the experience this past year was the latter, right? We had 4 medic teams that engaged with these events, right? And they universally were very positive and supportive of the potential that the tool had, but also the fact that it did something for them right now, right? And the first thing it did for them was just map the scene, right? And mapping the scene, it just gives you that initial gestalt. How many people do I need to go see? Is it a lot or a little? Do I have a general sense? Are they all over in this quadrant? Or are they in this quadrant? Or are they evenly spread out, right? And just kind of that even situational awareness is incredibly helpful in these kind of chaotic situations, because, a human, as soon as you show them the map, it's memorized. I mean, it's an instantaneous. It bores into their brain and they kind of like have that sense of where they need to go. It's almost intuitive once you've done it once or twice. And they were able to get that from this year's event, hands down.
Good. Perfect. Yeah, I could see, I wouldn't say not trusting it, but I'm guessing these medics didn't get a chance to like use it a lot to build that trust.
So they had about, I didn't talk about that, about an hour's worth of time to train with it. And there are certainly some medics, and just like every individual human, we have different thresholds for our kind of risk tolerance or our trust tolerance. Some people are willing to get into a Waymo vehicle in San Francisco or Phoenix or whatever and not even think about it twice. Some people are like, I'm not getting into that thing for another 10 years, right? And there's just why we have these different kind of risk profiles or tolerance profiles is not, I don't know that I know that literature particularly well. I know it's been studied, but it's not always clear to at least me why those exist. But they do. So we definitely had medics within our group that were more or less trusting of it. And I think there's risk there, right? So if you are overly trusting of a system that's not accurate, that's bad. And, we did witness one of our teams who, had gone and evaluated all the casualties that were on their robotic derived map. But unfortunately, the robot hadn't actually found, it wasn't one robot, but the autonomous systems, the group of robots had not found all the casualties yet. So they had a false sense of security that they had actually found all the casualties. They found more than the medic only team did, but it was still not 100% of the casualties. So they kind of stopped their search strategy. And what they did is they went back and started doing their secondary assessment. So like, okay, we got everybody. And they started going back. So it was a little bit unknown to them that they had missed it. And obviously the machine team didn't know that either, because we don't tell them how many casualties are on the battlefield ahead of time. In fact, this may even been the first time that some of these people are hearing that people were missed. But that happens in the real world too, right? I mean, the human folks miss some of these casualties. So again, we outperform the one run of human only teaming, which I think is very reassuring. And we have room to grow, right? And I don't have a problem with we have room to grow. We might have room to grow forever, but we'll keep working at it until we get to as close to perfect as we can.
Yeah, I don't mean like to downplay it. I think it's a incredible integration given time, right? Yes, some people trust technology more or less, but given enough time, you will definitely integrate. And I think giving these medics more time to trust what they're being told, then they're going to lean on it harder.
A lot of that time is not just in the moment, right? And we've actually, I think this may have actually been one of your major contributions to telemedicine in the military, right? We got to bring it to the training environment, right? This isn't you don't start in the operational space. You start in the training, right? And if it doesn't exist in that training space with the opportunity for medics to experience it while they're doing their training, they're not going to trust it when you get into the real world context. And we're certainly not there yet. But I think that paradigm holds true personally for nearly all technologies, right? If you don't use it before you go to the field, if you don't use it before your deployment, you shouldn't probably be using it on your deployment. There's just too much risk.
Looking, I guess, AI a little bit bigger, right? We're getting used to like these large language models like ChatGPT, Grok, blah blah blah.
Yeah.
We even have some medical versions. Like I had Stephen Blocker with Muru on. I think he's got a really good system going.
Great.
This is like a few steps ahead of that, in that it's not just pulling data from like vetted sources and saying its best interpretation of what has been fed, right? This is AI that's actually making decisions kind of based on what, right? Like we're constantly being reevaluating. This is how we do triage. We're doing, black, green, yellow, red. No, we're not. We're going to do this and this. We're going to change that. We're going to make it a triangle. We're going to do, we're constantly reinventing this.
Yeah.
How on earth can they build a model on triage, when we haven't really figured out what right necessarily looks like?
That's a really great question. And there's a lot of nuances to, I think, what you're asking. First of all, I think I should make it really clear. The robots were not actually triaging any casualty. We weren't in the DARPA Triage challenge. We're not suggesting yet. I'm really not suggesting like the medic should or shouldn't take care of that casualty. We're just trying to, make an accurate assessment and provide that information to the human team. And the human team ultimately at this point in time, and probably for the foreseeable future, is making some of those really critical decisions, right? Yeah. But, one of the things that drives me, and I'll just pause, kind of go back a little bit for one anecdote. As you've been in some of these mass cal scenarios, I've had many friends in these mass cal scenarios. We've all been in them. And as you approach that casualty and especially, I'll go back just for a conventional force medic. We've had these experiences of conventional force medics. It could be soft medics too, but their first really big event is a mass cal, right? And they walk into this scenario and they have to take care of the first casualty. And the first casualty is somebody they know, and they have to decide if they're going to take care of them, right? And then they have to live with that decision the rest of their life. And they move on to the next guy, right? And it's the exact same decision all over again. Do I take care of this guy? Do I not take care of this? Do I use the resources of my ruck or their ruck and then quote unquote waste the resource in somebody who might not survive? Even I think they might not survive, but there might be a chance. And then they do something and then they move on. And then they live for the rest of their life trying to figure out, well, did I make the right choice at that moment in time? And you replay these things in your head. And it's very difficult. And we learned this lesson with telemedicine. In fact, a lot of my job as the remote telementor, that remote expert, is just reassuring that medic that they're doing the best that they possibly can with the information in front of them, right? And you're doing exactly how I would if you were in a tertiary care medical center. You're doing okay, right? It may suck, but you're doing okay. So I really believe that the job of the tech is to promote the right information to the human to make the best possible decision.
Yeah.
And sure, there may be a point in time where, it's very easy for us to distinguish. Like I firmly believe if we can detect that the patient is already dead, let's not have humans waste time trying to do that assessment, because we do, right? We don't know if they're dead yet. We got to strip stuff off, get to a pulse, and we spend maybe 10, maybe longer seconds trying to figure out whether that person's alive. Well, that's just 10 or 30 or 40, 50, whatever number of seconds longer than, that you don't have to spend with somebody else. So if we can just kind of make sure we're really accurate in that part, that would be really helpful as a starting point, right?
Yeah.
And then if we could really accurately assess the next group of people that are so devastatingly injured, and we know that, and we don't know that yet, but let's just say somebody we know that, that's another group of people maybe we don't have the medics go take care of, right? They're pushing forward and always taking care of the people that they're most likely to save. And that would be a good place for us to be, both for the medic and for all of the casualty cohort, right? The medic wouldn't have to live with those decisions of should I have taken care of that guy or not, because they're just winning, right? They're just taking care of all the people that they can take care of. And I think that's a really good future state. Again, not there yet, and again, that's not necessarily having the machines make the decisions, but it's making the machines help with some of the prioritization. And the thresholds where you set that, we want to threshold that with the human needs to get there and make that final assessment, unless it's clear, 100% obvious, whatever that might be, right? And I think we can get to that point at some point in time in the future. Again, not there yet. Right now, the human is involved with all the decisions. Okay, so that's really important. You had asked some questions about kind of large AI models and where this is going. And I think the main point of it is for the foreseeable future, especially in medicine, we're keeping humans involved. And I had this conversation with Matt Heeman, who's one of our prior former, now retired general surgeons. I was talking to him about autonomous and robotic surgical capabilities, right? Which is a future direction that I want to go for surgery. And we were talking about kind of this threshold of where the robot can do it by itself versus not. And it's really hard to imagine an environment where we're going to ever trust a robot to do some of that work by itself, because there's this bond that forms, right? Especially in the military, where you go into battle because you trust the guy who's behind you,
Yep.
right? Not even that you trust yourself, right? Or even the guys that are next to you. Sometimes you do, but you really trust that guy that's behind you, that they're going to do the best they possibly can for you. And a robot will never have that feeling, right? It will never have that care for the guy that's in front of them. So I think there's always going to be a need to have that type of human in the loop component to what we do, and to ensure that we maintain trust with the system.
Yeah. Man, everything is just so dynamic. People are different. Their normal vital signs are different. How they react to things are different.
Yeah.
We were talking at work. We were talking about like the ultimate mannequin for training. Like how would he react and all the things you could do. And then I got
opinions about that, but probably too much for this podcast.
That's all right. I'm going to do another one specifically on mannequins and training and things like that.
When you want to do that, I'd be happy to talk, because one of the really cool parts about the DARPA Triage Challenge is, and it's taught me a lot about this, is the ability to do rigorously repeatable, high fidelity medical simulations. So, the DARPA Triage Challenge is a competition at its heart, which means that the competitors have to have a fair game.
Yeah.
And if they don't have a fair game, then they will protest.
Sure.
Right? So when we have these casualties that are in the field, we have to be so good at replicating them in a rigorous manner that the competitors can't protest the competition. And what that means is that when we replicate a 20, 30, 40, 50 patient mass cal, it's the exact same mass cal every single time. And I was going to make this point a little bit about your AI question. One of the things that, when we talk about all this chaos and this challenge of managing mass cal, because today we don't have a mechanism by which we can measure a mass cal, it's very difficult for us to understand what the best practices are on a mass cal. We get experts around a table and we talk about it all the time, but as you well know, like a SALT algorithm, right? Nobody follows a SALT algorithm or a real mass cal. We mostly just say, are you alive or are you dead? I'm going to help you if you're alive. If you're dead, I'm going to move on, right? And the help part is then a little bit more nuanced, usually on the second pass, right? And then you start prioritizing people. And I think that's why, the COTC decided to change the triage guidelines last summer, right? So we have a first pass and a second pass. That's actually what we do. We don't do SALT, right? And I think that's really important. But, as you collect this data with these, assuming that we have robotic systems or autonomous systems in the mix in the future, one of the things that computers and robots are really good at doing is being consistently reliable. So they will start learning from each event and they will recall that event over time and they will learn from each other because it's one system, it's not individuals. And if we were able to create high fidelity, rigorously repeatable, large scale mass cals, then we could actually study this in a way that would change how we deliver the combat casualty care in the future. And that's also, I'm hoping, a direction to go someday.
Yeah, I think especially for a competition like this, just having repeatability, because it's, I'm sure a lot of people are like, well, why couldn't a drone pick them up and fly them somewhere else? And like all these, added things, like it seems to me anyway, from an outsider looking in, and I'm old, it's kind of at its infancy. Like, could you find everybody, right? That's the first step, right?
Yeah.
Give me some basic, left and right limits on their physiology. And like that's in itself, that's a pretty difficult challenge to program a drone or of some kind to be able to do those things.
Yep. It's taken 2 years so far. And again, this year, the teams did phenomenal in the task. And because they did so phenomenal in the task, we're going to push really hard next year at competition number 3. So, stay tuned. Hopefully we'll have some really good opportunities for people to come maybe observe or visit or at least watch online some of the work that we're doing for the competition next year. So,
but the point I was trying to make with the mannequins as far as training, it's that repeatability. Like it's A plus B always equals C. Like there is no thing like that. However, real life, it could be C, it could be sometimes D, right? Or X, right? You do the right thing by every algorithm, and sometimes the patient doesn't do well. And I can imagine with a robot based on an algorithm of triage or surgery or anesthesia or however, that's going to be a difficult hurdle when the inputs and outputs don't always equal what it thinks it should.
So is that a core challenge you think from the training domain? I mean, is that really something that we got to figure out?
It's a challenge. It's a challenge for human instructors to not to be able to give that realism, right? And in the trauma lanes that we were on, right? We're inputting like, hey, sometimes things just happen and you have to be prepared for it. You see it, and I don't necessarily mean it to get into, the values of different training models, but like LTT, man, it's about as perfect as you can get shy of what you're working on. And the differences between that and reality, it's the unpredictability of like, sometimes they're sick and they have this problem. Or you thought giving them 1 unit of blood was the right answer when it wasn't. Right now, things have gotten worse for some reason. That's just extra weird. I don't even know why that happened, but you still have to assess what is the problem, what are we going to do going forward, and that's a real trick.
Yeah, you brought up some of the large language model kind of things earlier, and I really do think, I mean, even today off the shelf, I don't remember the name of the app that you mentioned earlier, but Open Evidence is one that's common in the clinical domain now. Up to date, I think everybody probably knows Up to Date is starting to add some AI tools to it. You got to be really careful with some of the off the shelf LLMs, GPT, Gemini, things like that, because they still hallucinate and still lie to you specifically about medicine. So be really careful with those. But some of these other tools are getting a lot better at just being able to answer questions off the cuff. And, I think that, as those LLM tools grow and have, and are more tuned, right? They're trained, on a on specific scenarios and data that is relevant to the context that they're gonna be used in, then they will only get even better, right? I had someone challenge me the other day, you know, could a LLM off the shelf describe, we talk about annotating data all the time for AI. Like someone's got to go and put bounding box on or describe what they see. Essentially what we've done with capture phrases for decades now, right? You have a human describe what's in the image. Well, LLMs are so dang good these days. I mean, you can give it a fresh image and say, describe what's in that image, and it does a pretty good job. Well, if it can do that well, then can then also tell you what to do next. This person should have all these things done to them. And the answer to that question is off-the-shelf LLMs can actually do that reasonably well, right? Maybe not for every context that we're in. So I do think that we will see more of a proliferation in our near term of the tools that will start to, give us that information. One of the hard parts, not for this maybe community, but is getting some of those tools through the FDA, right? Because people are using them on the street now. I don't know how safe they are. How do we actually, review them and determine whether or not they're safe, accurate, reliable, consistent, and they're not going to, give bad information. As long as they say they don't know, like a good human with good judgment, as long as the machines could have good judgment, that's not figured out yet. But if we can figure that out, how to give a machine good judgment to say, I know what I know and I know what I don't know, that would be, pretty profound, I think.
Yeah. I mean, like you mentioned, just looking at a picture and being able to tell what resources are needed, like that would be huge on the logistics side. Because it's essentially, we have 20 casualties. We need, I don't know, 30 tourniquets. The medics only have 12. We need another drone to deliver the X remaining. You know what I mean?
Stay on the lookout. Data competition from DARPA Triage Challenge coming to a online forum near you sometime, hopefully soon. Well, this year. So that's that whole issue of resourcing. What casualties need as a resource from a resource perspective is part of that secondary triage competition that I mentioned earlier for the data side of the house. Tell me all the resources this casualty is going to need over the next 4 hours. That would be really helpful. And oh, by the way, if there are, phenomenal users that are out there that are thinking about how to code for some of this stuff, we do have opportunities for self-funded teams in both the systems competition and the data competition. And those registration sites are open out the DARPA Triage Challenge online location.
Nice. I wish I could, because I'd like to play, but
There's
can't
somebody
use
out there that knows how to do this really, really well.
I keep forgetting my password on my email, so. When it comes to, like we mentioned in the future, maybe some of the challenges, you mentioned the logistics going forward in I guess this year's challenge. What boundaries are you trying to push?
Wow. Specifically for the DARPA Triage Challenge, or just for Jeremy Pamplin at DARPA in general?
Well, let's take the easy one, the DARPA challenge.
Okay. So, the DARPA Triage Challenge, future state for this year is really a validating that the teams can not only find the casualties, but can do accurate assessments consistently in a speedy manner. It is really I would say the thrust for this year. That's why we divided this up into the gate section and the human machine teaming section. That gate section, in my mind, is really important for the trust of the system, right? If you can't If it doesn't, we should be able to get an average, an expected performance of these systems, right? So you kind of know what the probability is of this system that I'm using today finds all the casualties. It finds them consistently 89% of the time. Okay, well, that's pretty good. Why can't it be 95% or 99%? And that's, those are the boundaries that we then need to push in the future. But, we want to this year try as best as we can to get, some actual a volume, cycle runs of more teams running scenarios more than once, so we can kind of get some averages and understand what their kind of performance level is within that. And that helps us understand trust in these systems. I would say that's probably the boundary that we're pushing this year. It's really a lot of it in many ways the assessment boundary. The teams themselves, again, the running the algorithms, doing the machine teaming, because they have more than one, system that's on the course at a time. It's usually several UAVs and several UGVs. They all got to work together, right? And how to get them to work together in a manner that is efficient, effective, and doesn't run over casualties in the middle of the scenario, right? You don't want to cause harm to anybody. So those are still really hard challenges that they are working through, while doing the assessments of the casualties, while communicating to the humans that are on the ground. One of the things that's really hard about medicine and trust is that the machines should, when they're not operating on their own, they are, they're responsible for interacting with the humans, and human machine teaming and human machine integration or interactions still it's a very challenging field of science right now. And I don't think we have all those things figured out. I think that's in the DARPA, the systems competition. That's the big parts this year. In the data competition, again, the teams are looking at the data for 4 hours worth of collection and trying to figure out immediately what the map is of casualties over the future, right? How do I map that casualty out? How do I predict what's going to happen to them for the next X number of hours? Could I predict down, exactly when they need a specific life-saving intervention or specific intervention? That would be really cool, right? Because then we can turn that into clinical decision support. Can we match that to the resources that are needed? That would be really cool, because then we can better maybe sort right from the get-go for all of our casualties. So those are some of the data challenge elements that we are asking our teams to do this year. Again, open to self-funded teams as well as the teams that we are funding to do this. I guess maybe future DARPA stuff, as part of the Biological Technologies Office, the BTO, which is where I work in DARPA. We are focused, I would almost say laser focused in many ways, on what we call the live chain, something I've previously called the survival chain and have described. But, this is akin to, what warfighters might call the kill chain, right? So, sensing, assessing information, getting that information, the right decision maker at the right time to make a decision about a kinetic action that will, outperform your adversary. So in the medical side, we're not so much into the take out the adversary, right? We're into how do we save lives? How do we get them off the battlefield? How do we return them back to the fight the fastest we possibly can? So that's that's the live chain, right? How do we maximize the speed at which a casualty can move through the live chain in future warfare? And, the challenge that we have in future warfare is not just that we are, disaggregated, working in small units, working a long way away from other people, or have challenge with prolonged field care. Obviously, this is what this, community is about. How do we, when we are in those situations, or we have, lots of casualties, how do we build capability around an individual casualty so we don't have to move that casualty? Right? How could we turn a medic into an 18 Delta? How do we turn an 18 Delta into a highly skilled physician assistant? How do we turn a highly skilled physician assistant into a trauma surgeon, right? How can we turn that medic into a trauma surgeon? How can we get a robot that was a trauma surgeon, right? I mean, these leaps and bounds that we have to make at some point in time to be able to deliver the capability that's necessary to save lives wherever the casualty is. Because what the casualty wants, if you're going to be a casualty, is to have immediate life-saving care in a level 4 trauma center, right? The best trauma center in the world. I intentionally said level, 4, kind of role 4, but, someplace that's beyond the best. That's what every human wants. So is there a way that, we could replicate that in some way, shape, or form with advanced technologies and the humans involved such that we can save everybody? I really, so, my son's joined the military as well now, right? And this keeps me up at night, right? I worry about maintaining a survival rate that we've had for the past 20 years of our lifetimes in a world that is way more complex that, the future fight is going to look like. It's a lot more challenging, I think, than we experienced, and what we experienced was hard, right? And is there a way that we can continue to deliver the survivability, the quality of life that our sons and daughters have come to expect from us for the last 20 years? And I know that it's going to be hard to do. I know that it may not be 100% possible all the time. In fact, it's probably not. But I think that's my job, to continue to work for that and to continue to try to find solutions that will get us closer to it. And that's what the BTO live chain is really all about, is really compressing all the capabilities that we have out there and finding the ones that are going to be most effective to be able to deliver them as fast as possible, as far forward as possible, so we can get the most lives saved and get the most soldiers back to the battle when we can and back home when we can.
Hey, Jeremy, I really appreciate you jumping on and walking me through this.
I am honored. I'm humbled that you would ask, a little bit of an old gray hair like me, who's no longer in some of those fights, but still very passionate about, supporting the warfighter and supporting the medics that are out there, for you having me on the show. So I really appreciate you too, Dennis.
That's it for today's podcast. Make sure to go to our website, www.prolongedfieldcare.org. Check out our free downloads and a ton of other helpful information. Grab a bag of our fresh roasted PFC coffee, links in the description below, and stay on the bleeding edge of combat and austere medicine. This is Dennis for the PFC podcast. Out.